So it's 12 noon. I'd like to get started. Welcome everyone to Medical Grand Rounds. Just a reminder before we get started to please leave the questions till the end. If you can enter the questions in the chat, that would be appreciated. As well, please answer a brief questionnaire that will be sent to you after the Medical Grand Rounds. This will let us know that you were present today. So our Medical Grand Rounds today are brought to us courtesy of the Division of Radiation Oncology, and I'd like Dr. Tarek Ejal, who's the Chief of the Division of Radiation Oncology, to present our speaker today. Tarek?
Thank you very much, Dr. Janetti. It's with great pleasure that I'm presenting Dr. Sergio Faria, a radiation oncologist at the McGill University Health Center, as well as McGill University. Dr. Faria comes from Brazil, where he actually trained before doing his fellowship at Stanford University and ultimately joining the Division of Radiation Oncology at the McGill University Health Center. Dr. Faria's specialty or subspecialty is genitourinary cancers, colorectal tumors, as well as lung cancer. And SBRT, the topic that he will be presenting today, has really developed with lung cancer and more recently with prostate cancer. So it really fits in all the domains he practices in. So thank you very much, Dr. Faria, for your kindly accepting to present to Medical Grand Rounds today.
Okay. Good afternoon, everybody. Very happy to talk about radiation oncology today. And the title of this conversation is The Evolution of SBRT. As you know, SBRT is stereotactic body radiation treatment. And another title for the same topic could be external beam radiation from conventional fractionation to extreme hypofractionation. The reason I'm talking to you about this is because radiation oncology is a little bit unknown specialty, I feel. Everybody heard about radiation oncology, but nobody really knows what we do here. And part of this is because we don't have really students rotating with us. Radiation oncology is being considered very technological. And that reminds me of my mom. I've been doing this for 40 years, and she keeps asking, Sergio, what is that thing that you do in the hospital? She doesn't know much. And I still have people that call me radiologists. So I decided, okay, I'm going to show in a way that everybody understands without technical terms or data. But this is an amazing change in the last 15 years, which is the evolution of SBRT. So let's start with this. This is a lung cancer patient, as you see here, right lung cancer. And after appropriate staging, this is the only site of the tumor. There is no mediastinal or distant metastasis. This patient has indication for surgery. But clinically, he has no condition to do surgery. So he came to be treated with ablative radiation. And this is curative radiation. How do we do it? We need to do a plan. And this is the plan. This is the isocenter, a very important point here, because this is where the LINAC, the linear accelerator, is going to turn around. So it's very important to precisely determine where this point is. I'm going to show you later how we do it. In this plan, as you see, is a semi-arc. And how it happens, practically speaking. Well, the patient arrives few minutes before the treatment, and there's no need for pre-assessment exams, there's no need for fasting, no need even for PFTs, in spite of being a lung cancer. So the techs help him to lie on the couch. This is the couch, this is the LINAC, the linear accelerator. You see here the lasers, and there are different methods to put the patient in the precise position. I'm going to show you later how you do it. And this is probably the longest part of the treatment. It may take, what, 10 minutes? Once this is ready, the patient, the techs leave the room, and we tell the patient, Mr. X, don't move. You're going to be treated. And they press the beam on, And here you see the linac turning around the patient. He doesn't feel anything. What's going on here? This, you see all these leaves moving in and out, allowing the radiation to be blocked or to pass. And where is this? Here, in the head of the linear accelerator. And that's it. It takes few minutes. The patient doesn't feel anything. And this is SBRT, also called SABIL, stereotactic ablative radiation, and also called extreme hypofractionation. And amazingly easy for the patients. That's the reason we can do this even in frail patients. Anybody can do it. It's very fast, as you saw. It's a non-invasive procedure that gives tumor control similar to surgery. Do we have randomized trials in a way that you can say that the tumor control is similar to surgery? A short answer is no, we do not have. We tried. When I say we, it's the whole world. Tried to do studies comparing SBRT to surgery, for instance. And it's difficult. Even here at McGill, we had a few years ago, for 2 years, one study, randomized studies trying to compare SBRT with the surgery. How many patients we put in that study? 0. Why? Because it happens everywhere. It's difficult to do these studies. I'm showing here a publication of 2020, and this is from UK. They tried to do a study comparing SABIL with surgery for stage 1 non-small cell lung cancer. What did they find? They concluded that a phase 3 randomized controlled trial randomizing patients between SABIL and surgery is not feasible. Why? Patients have pre-existing treatment preferences, and this is a barrier for recruitment. Not only patients, even doctors, we all have pre-existing preferences. Interestingly here, significant proportion of patients randomized to surgery declined and chose SABIL because SABIL is so attractive, it's so easy. So what happens here? This is what I'm going to talk to you about, because until the beginning of the year 2000, radiation oncology was not a very interesting specialty. Some people believed, including myself, that radiation oncology could die as a specialty. We treated a lot of normal tissue, a good percentage of toxicity. So not many people wanted to become radiation oncologists. And this is an article that Dr. Zeitman, I don't know if you heard about, Dr. Zeitman was until recently the chief of radiation oncology in Harvard, Boston, and also the editor of the Red Journal, the International Journal of Radiation Oncology. And in 2008, he wrote this article about the future of radiation, also the survival of this dying specialty. So how come we had in the 15 years ago a specialty that nobody wanted to become to a specialty that now can do SBRT? So what happened is that the last 15 years, we had a lot of things, amazing things, such as IMRT, IGRT, 4D CT simulation, amazing planning systems. What do they do, the planning system? They do the calculation and show us how to deliver the radiation. The modern plan systems, they can tell you with precision the dose being delivered to any part of the body. It's amazing. And with all these together, we can do not only SBRT. Another technique that I like very much is called SIB. SIB stands for simultaneous integrated boost. And we do this every day for different tumors, including, for instance, high-risk prostate cancer. We give 5 fractions. And what is SIB? We are able to give it to 2 targets or more, if needed, different doses at the same time. It takes few minutes. And this is not only for prostate cancer. We do this in many sites. For instance, this is a case of seminoma. A patient had a surgery. Months after the tumor came back in the para-aortic region here, the case was discussed in our tumor board, and we decided to treat him with radiation. Seminoma, as you may know, is very sensitive to radiation. And we give the para-aortic and the ipsilateral iliac nodes a low dose and a boost at the same time to the visible tumor. This is SIB, simultaneous integrated boosts. Similar to what I showed you for the lung cancer, the patient lie on the couch here. It's very easy. And after the lasers here, once the patient is ready to go, we have the plan for the prostate. As you see, we try to irradiate the prostate and to protect as much as possible the rectum, the bladder here. In this plan is a whole 360 degrees. This takes few minutes when the beam is on, and the patient leaves the room walking the same way he came in. So this is what I'm going to show you, the evolution of this, mostly with images in an easy way that everybody understands. The use of ionizing radiation for the treatment of cancer, surprisingly, I find, it started a few years after Röntgen described X-rays in 1895. I find this amazing because in those days, of course, nobody knew how dangerous ionizing radiation can be. And of course, they didn't know how to measure ionizing radiation. So how can you prescribe a treatment if you don't know? Well, in those days, you know, X-rays, the maximum dose was at the skin. So they came with this inventive way calling dose erythema, as the name says. You keep giving radiation until the skin complains and start becoming red. Simple like that. And until not long ago, what, 30 years ago, we used cobalt units to deliver external beam radiation. Until the mid-50s, when the first LINAC, the linear accelerator, was used at Stanford in California. And I had my fellowship there. They feel very proud to be the first institution to use a medical linear accelerator. You see how old this was. And of course, the new LINACs, this is a modern LINAC. There's two brands. This is Varian. And Varian started at Stanford, and they're still there at Stanford, California. We have mostly two brands of LINACs. One is this US-based Varian. The other one is Electa, based in Europe. And these are the modern LINACs. I'm going to talk about them a little later. We have 5 of these machines here at the Cedar Cancer Center, but this is not the only machine. We have another machine, a CyberKnife. It's a beautiful machine that is a robot. As you see, it follows, it tracks the tumor. We have one of these machines here at McGill. We had, when we were at the Montreal General Hospital, this machine at thermotherapy. We don't have it anymore. But the reason I'm showing this is to show you that we have different ways to deliver, to do external beam radiation in modern radiation treatment. I don't know if you can see here because this is, until the year 2000, external beam radiation was mostly playing with fractionation. And what is the convention of fractionation? Typically, we give one treatment a day. And between 5 and 6 weeks in this schedule here, we have 1, 2, 3, 4, 6 weeks, but you have this between 5 and 7 weeks, one treatment a day, typically 2 gray per day, Monday to Friday. I never understood exactly why in radiation oncology you don't treat patients on Saturdays and Sundays. I love it. I heard many talks about this, and it seems there is some religious thing, but conventional fractionation, 5 treatments, working days for 5-7 weeks, once treatment a day. Why we do this, or use it to do the conventional fractionation? Because as you know, until not long ago, we included in the fields of radiation a large amount of normal tissues. And we kill normal tissue as well. So doing this, with this 24 hours of fractionation, at the end, we would be able to kill more cancer than normal tissue. That's the idea of having this interval, because the repair of the sublethal damage to the normal tissue was better than the cancer. So external beam radiation in those days played with different types of fractionation, for instance, hyperfractionation. As the name says, it's more fractions than conventional fractionation, typically 2 treatments a day. And usually you need 4 to 6 hours interval. And this is very, very inconvenient for the patient because imagine the patient coming from far and he does 1 treatment in the morning, needs to wait 6 hours for the second treatment. So we never liked it very much here at McGill, but still people do routinely this hyperfractionation in cancers such as small cell lung cancer. It's very standard. As a matter of fact, the guidelines say that one alternative for standard is hyperfractionation in small cell lung cancer, 2 treatments a day. Accelerated fractionation is when you need to decrease the total duration. So you give 2 treatments a day, but you decrease the total number of weeks. Another way was concomitant boost. As the name says, we start with conventional fractionation. And in the last week or the last 2 weeks, we add a second treatment 6 hours after as a boost to the primary tumor. And this was used very much. Even today, I think people use it for instance, head and neck cancer. This is a split course. As the name says, we need to rest because of the toxicity. For instance, in anal canal, squamous cell carcinoma of anal canal, as you may know, we can cure 80% of the patients with radiation and chemotherapy. But because of the location, and depending on the size of the tumor and the sensitivity of the patient, we can cause a dermatitis, and we need to rest. And this was used until not long ago for anal canal, the split course. But from all these different fractionation regimens, the one that we use it today with the new technique is the hypofractionation. And as the name says, it's less number of fractions compared to conventional fractionation. Of course, we need to increase the dose of each fraction. In the beginning, we call accelerated hypofractionation when you mention decrease of the total duration. Today, we call hyperfractionation less number of fractions and a shorter total duration of treatments. This is what we do today. So imagine in the beginning of the year 2000, here in McGill, if you had a lung cancer or prostate cancer patients, we need to give 35, 40 fractions. That means 2 months in a row the patient come. Imagine the guy come from Saint Jérôme, 40 fractions. So when we start doing hyperfractionation, we start with half of the number, 15, 20 fractions. And this we call moderate hyperfractionation. And for the last 4 or 5 years, we're using now what we call extreme hyperfractionation, which is 1 fraction or 3 fractions or 5 fractions. So imagine the amount of comfort for a patient that doesn't need to come 40 times and comes only half of this time or even 1 week. So this is what I'm going to talk to you about. So how come from a dying specialty in the years 2000, we moved to what we do today? The first information that not everybody is aware is that ionizing radiation is still today the most effective single agent against cancer after surgery. I'm talking about adults, of course. So this is squamous cell carcinoma. I like this because it shows the big tumor of the skin. I treated this in Brazil, and we know how to cure these patients. To cure is 90%, 95% of the patients we can cure. As you know, in adults, most of the common cancers, they are either squamous cell carcinoma or adenocarcinoma. And these tumors are very sensitive to radiation. If you use conventional fractionation and you know how to deliver, we know how to cure the cancer in a way that we don't give an ulcer here that we never heal. We know what's going to happen with the normal tissue here. And this is the same patient. So this is the reason of the investment in technology, because ionizing radiation, if given in an appropriate way, can be very effective against cancer. A major change in external beam radiation came in the 80s, mid-80s, with the introduction of the CT simulator. It's the use of CT scan that is going to simulate all these lasers here that are in the LINAC, where it happens in the LINAC, the linear accelerator. And we call this a 3D, instead of doing a direct field like this, we did a 3D radiation plan with the CT simulation. This is an example. In this case, it's a rectal cancer. We do the contour of the target. And in those days, the technique used was called stop and shoot. As the name says, we stop the machine, give radiation here. We turn the machine, another field, another field, another field. In this case, you have 5 fields, 1, 2, 3, 4, 5, turning around the isocenter here. And the idea is the same, to give radiation to the target and the minimum possible around the target. But imagine, each field has a different shape. How did you deal with that those days? Oh, a lot of work. We need to do these custom blocks to shield normal tissues. All these trays. So for this patient with 5 fields, we should have 5 of these trays. And we put these trays where? Here, in the head of the linac. Imagine the amount of work and the time, because you need to stop the machine, the techs go into the room, change the tray, again for this, again for this, again for this. So the major change that came after was, I don't know if you can see well here, these leaves here in the head of the linac. I'm going to increase this. You see these leaves here? So this is, in the beginning, to just have the good shape for each field. But soon, the engineers, the physicists realized, well, if you move these leaves when the beam is on, we can modify the amount of radiation being delivered. And this was the beginning of IMRT, intensity modulated radiation treatment, because you modify the amount of radiation with the movement of those leaves here. This was a major achievement in external beam radiation because for the first time, we could give radiation to a site of the body with a hole in the middle without radiation. It was impossible to do this before IMRT. A quick movie, because a movie sometimes shows better than 1,000 words. So beam on, the leaves moving, and this is what allows us to give less or more radiation. IMRT. We couldn't do IMRT if we don't have a planning system. What is a planning system? It's a very complex, sophisticated software that can calculate the dose being delivered. We have many tools used with the planning system. One is this, the dose volume histogram. And I show you this because, you know, some radiation oncologists, they send a picture of this DVH as the report of the radiation oncology. And this is interesting because it shows the dose here. In this case, it's a SBRT of a lung patient. The dose given is 48 gray in 3 fractions. We call the PTV. This is the planning treatment volume, the target. And here's the volume. In this case, it's relative volume, percentage. So this curve is showing that the PTV, 100% of the PTV is receiving the prescribed dose of 48 gray. What about these other curves here? These are the normal tissues. As you see here, spinal cord, left lung, right lung, heart, carina, esophagus, whatever you want. And these are normal tissues. We want this close to 0 here, distant from this guy here. All this is new. We didn't have this control of normal tissues as we have today. And how do you know the dose to give? Well, we have what we call normal tissue constraints, as the name says, different doses to different volumes of normal tissues. And how do you get these numbers? Academic institutions such as our, McGill, we just work, do reviews, and our Department of Medical Physics is very good on this. This is an example of publication 2019 from us here, McGill. Chest wall pain, falling SBRT, 48 gray in 3 fractions. As you may know, small percentage of patients can have sexual wall pain after SBRT, and we try to correlate some those fractionations with the pain. This is another publication, 2010, when we start doing hypofractionation to prostate cancer, and this is searching for those volume constraints for rectal toxicity. So this is one way to have the constraints, to academic institutions looking for that. But because SBRT is being used so widely to every service of radiation oncology and most non-academic, of course, we have today a series of publications with normal tissue constraints for any site, abdomen, chest, and this is still a evolving topic. It's not the end. We always learn depending on the amount of normal tissue and the number of fractions. Again, this is a planning system. The only way that we can do today what we call arc therapy, as you saw the LINAC turning around the isocenter here, is because we have this sophisticated planning system that are able to calculate the dose with the movement of the LINAC. We couldn't do this in the year 2000 with the stop and shoot technique. The other thing that happened, and it's amazingly important, is the introduction of CT simulation of 4D. Remember, the 80s, we had a 3D simulation. What is a 4D? The fourth dimension, here's the movement. This is a movie that I did with my cell phone, and you see the movement of the tumor, axial view, sagittal view, coronal view. You see the green thing here is the contour that we call ITV. Encompasses all the movements of the tumor during the breathing cycle. How could you do SBRT without this? And again, this is relatively new. We didn't have this about, what, 15, 20 years ago. Another thing that happened at the same time was a major improvement in the quality of imaging in general. As you know, the CT scan 4 years ago were much worse than now, and MRI is the same. But not only that, the introduction of exams such as the PET scan that we didn't have 15 years ago. And we were able to fuse the CT simulation with any sort of exams, with PET scan, ultrasound, MRI, other CT scan to help us to locate where the tumor is. This is an example of a pancreatic cancer in the right lung. You see the right upper lobe is collapsed. We know that the tumor is here, but we don't know where because the CT doesn't show there's a collapsed lung and tumor. So, but if you fuse with the PET scan, voila, we have the tumor in front of us. Imagine how useful this is now, these days, when you have a small oligometastasis or progression lost in the middle of the abdomen or in the bone that we will never be able to find without these modern exams like PET scan. But this is not only for the tumor. We use the same idea of fusion in the CT simulation to find normal tissues. For instance, this is a prostate cancer CT scan. We know the prostate is here. We know that the rectum is here, but we don't see where is the thin line dividing prostate and rectum. But if you do an MRI, 100% of the times we see, I don't know if you can see well here, the line between the rectum and the prostate. And here at McGill, we have a devoted MRI to do this. And we can fuse after with the CT, and we can contour in the CT simulation precisely where the normal tissue is. This is very important today. Here are a few words about the medical physics. We cannot work in radiation oncology without medical physics. They are responsible for everything we do, from quality to know if we are delivering the dose in an appropriate way. And this is an example. For instance, I showed you that we have for each site, depending on the prescription, a series of constraints. And this is the sheet of constraints for extreme hypofractionation, SBRT for prostate cancer, 5 fractions. Until not long ago, it was a kind of manually done to see if each one of these constraints were respected after the plan. This is a kind of time-consuming procedure. And for the last few years, thanks to medical physics, we've been doing this quality assurance meetings every week. Here we have the teams. We have different teams, specialized teams, a team for brain, a team for breast, a team for sarcoma, a team for lung, and so on. And who participates in those meetings? not only the physicians, but the medical physicists, the dosimetrists, the students, the residents, and we discuss every week before treatment if the patient has good indication for radiation, if the contours are okay, if the normal tissues are okay, but mostly because of the use of this script, is a software, we can do in seconds to check if all these constraints are respected, and we have this green light saying, yes, all the constraints were respected, or sometimes we have one or two red flags, and we go after the plan to see if we can change, if we can accept the planning, etc. Here I need to give you a few words about SRS versus SBRT. The S here is the same, it's stereotactic, because it's spatial. Radiosurgery, this is for the brain. Radiosurgery, stereotactic radiosurgery versus body. This is for the rest of the body. It's interesting because it took about what? 20 years for us to be able to do SBRT, to do pretty much what we knew how to do in the brain. And I mention this because McGill was a pioneer in this. I'm very proud to show these slides. Some of you probably saw these many times, but this is, I think, Dr. Portugal-Sack. In those days, I'm talking about the 80s. For the brain, literally, we put some screws in the skull of the patient. And this is the proof of the crime. You have a screwdriver here. And this frame is fixed in the skull of the patient. And with this frame, we did the CT simulation. After this, we did the plan to find this isocenter here. You see the references here of the frame here. And it's still with the frame in the head. The patient went to the LINAC. I think this is Dr. Suhani here, Dr. Portugal-Sack, an old LINAC. And one thing that I find amazing with the radiosurgery that McGill started doing, most of the institutions, it's only the head of the LINAC that turns around the brain here. But the technique in McGill was amazing. I'm very happy to show this, I think, because it's not only the LINAC that moves, the couch moves as well. I find this amazing. Look at that. This is in the 80s. I think few institutions in the world used to do things like that. But anyway, everything started with the brain. The brain doesn't move during breathing, so this helped a lot. And not only that, we know today we don't need to put screws into the skull of the patients anymore. We have these masks, and most of the radiosurgery we do at the CyberKnife here at McGill. But many years after, when we started doing SBRT, we try to copy what we did with the brain. With all these immobilization devices, complicated the frames, trying to reproduce in the LINAC what we did during the simulation. But the problem is that in the chest or in the abdomen, tumor organs move during breathing, doing other things. And very unfortunately, we could not put screws in the abdomen or the chest of the patient. So it took a good number of years that we tried all this until we have a very important sophisticated tool called IGRT, image-guided radiation treatment. So when we start having image-guided radiation treatment, we ask to ourselves, do we really need all these crazy things to do SBRT? Because with image-guided radiation, we are able to have what we call CBCT. I will show you what is this. But this is a CT scan that you do a few minutes before the treatment. And you can compare with the planning CT. For instance, when you start not doing this anymore, with the medical physics, we did all sorts of patients to CBCTs before the treatment, right after the treatment, to be sure that we're treating the same volume in spite of not having all this. And yes, we are able to do it. And that's the reason today, we don't need all those devices and the patient goes directly to the couch because of IGRT, image-guided radiation. I'm going to show a quick movie because I think it's interesting. So these wings here of the modern LINACs, they do the CBCT. The patient is ready to start treatment. This is done. The CT, the CBCT is compared to the CT planning. We can make corrections. 1 millimeter right, 2 millimeters up. And after that, we do the real treatment, in this case, to the prostate. And this is image-guided radiation. We don't need all those immobilization devices, and the treatment is very safe. And because of this, we treat well less normal tissue because we don't have a big margin. We know precisely where the tumor is. The use of hyperfractionation brought consequences to us here at the MUHC, and I need to talk a little bit about them. Sometimes good things, sometimes not that good things. So what was good? I think one of the most important good things, because we are pioneer in SRS and in hyperfractionation in many ways, as an academic institutions, we published a lot in good medical journals, in good journals of medical physics, and we involved a lot of residents, fellow students, and this is what an academic institution is for. The other thing that I think we should be very proud of is that because we've been using hyperfractionation since the year 2000, most of the patients, they are treated with hyperfractionation, and this is moderate hyperfractionation or extreme hyperfractionation, including in organs such as liver or kidney that very sensitive to radiation. Before SBRT, we didn't treat these patients. And what is the result of this? The result of this is that we treat more patients than any other institutions, radiation oncology institute in Quebec. And I think we should be proud of this. This is Dr. Rijal gave me this slide from data from 2020, 2021. These are the 13 services of radiation oncology in Quebec. And we are here, Kuzum. And this is the median number of fractions for each treatment. You see, we are the institutions that use the smallest number of fractions, 8. Some institutions use 2 times more than us. And this is well more, giving less number of fractions. Of course, it helps the patient because he doesn't need to come very often. But above all, we have almost no waiting list to start patients. As a matter of fact, we've been saving all these guys here. They've been coming to MUHC because we were able to treat them. And most of the reason is because you use hyperfractionation to almost every site. What is not as good because of hyperfractionation? One thing that I find is kind of sad is because we don't use more brachytherapy for prostate cancer. As we used to do a few years ago, it's very rarely that you have a prostate cancer treated with brachy here. Contrary to what happens in the rest of services in Quebec and in Canada, everybody uses still brachy. Why we don't use it? Because the patients don't want. When they hear that we have external beam radiation, a hyperfractionation, they say, I prefer this than having an invasive procedure. Truly speaking, there is a decline in the use of brachytherapy everywhere. This is a publication 2014 from the MD Anderson. And the fact is, the reason for this decline is because of hyperfractionation. But here at McGill is one of the few radiation oncology that is not using brachy anymore. I think the most important downside of hyperfractionation for us is because McGill, as you may know, thanks to Dr. Suhami, I find, is very connected to RTOG, now NRG. McGill has been an elite member of RTOG, and the reason is because we are able to accrue many patients. As you may know, to be part of the elite member of RTOG, you need to accrue a minimum number of patients every year. And McGill was very good on that. As a matter of fact, for many years, McGill was #1 to accrue patients. However, what happens? This is an RTOG trial that we had open here. 1,500 patients. This is for prostate cancer. Big number of patients. This is another big trial. You see 2,500 patients for prostate cancer, open here at McGill. But we could not accrue patients. Why? Because the only alternative of external beam radiation this trial accepted was conventional fractionation, 44 fractions. We couldn't sell the trials for patients. The patient said, why am I going to do 44 if I can do 20 treatments or 5 treatments? And this has become a major issue for us because we cannot or have difficulty to accrue patients in the arterial trials. I couldn't finish this conversation without mentioning a big area open with this technology of SBRT, and this is what we call functional radiosurgery, because it's in an area that we're treating not only tumor, but organs that need ablation. And this is an example you heard in June last year. This is the McGill team doing this great work, treating ventricular tachycardia with ablation of a part of the heart. It's not tumor anymore. And this is growing. One area that I think we should be involved in, because as far as I know, nobody here at McGill is involved. And I invited people from the M&I or neurology, because this is a review, 2022, LINAC-based radiosurgery for functional, neurologic, and psychiatric disorders. This is another review of the same title, functional radiosurgery for brain. What are the targets? Well, they have all sorts of targets for different diseases, but one that I saw, the French are very well developed on this, is I saw ablation of thalamus for tremors with amazing results. And as you see here, there are many indications, and this is an open door, what we call the functional radiosurgery. Okay, my friends, I think it's time to finish. This is my last slide. This is a picture of the last Christmas party that we had in December, with still the masks, very unfortunately. I need to thank the big family that is radiation oncology. Many of the slides that I showed you belongs to colleagues, and I thank them for that. It's impossible to do radiation oncology without a team. I don't know even to turn on the machine, the LINAC, and we depend on each other here. It's a beautiful team. We have more than 100 people working here. So I hope you have enjoyed this quick and try to make it easy to understand how amazing is technology, all the evolution that happened in the last 15 years that made a dying specialty becoming, in North America, one of the most wanted specialty among young medical graduates in North America. Thank you very much, and I hope you have enjoyed. Thanks.
Thank you so much, Dr. Faria. Really wonderful, very interesting. I can tell you that I've learned a lot. I didn't know that we were advanced like this. Tarek, I know you have to leave soon, but before you leave, would you like to make a comment before you have to run out to accreditation?
Thank you very much, Dr. Janetti, and thank you very much, Dr. Faria, for the presentation. It's clear that we're moving forward in radiation oncology. We're a very technology-based field, and technology is only improving year after year. We're treating better, we're treating in shorter amount of time, we're treating hopefully with less side effects because of how we use technology. So I think it's important for clinicians that are not necessarily radiation oncologists to keep that in mind, because we tend to always remember the side effects of treatments that we gave 20 years ago, 30 years ago, because that's the kind of follow-up we have. And we tend to forget that what we do today is a lot safer, is a lot less morbid than what was done a long time ago.
Fantastic. I invite people to enter their questions in the chat. I have a big picture question for you. Are there, obviously you have, very advanced technology right now that has changed the landscape. But if you look at in the last, say, 5 years with the newer technologies that you're using, are there cancers that were not cured historically that you can now cure with this therapy?
I think yes. For instance, liver and kidney are very sensitive to radiation. So until all this technology were available, we couldn't really give radiation to liver or kidney because we killed the organ. and we couldn't see well where the metastasis in the liver is. But now, with this new technology, we give, if not curative, when you treat oligometastasis in colon cancer, for instance, sometimes we cannot cure, but we prolong life many years with this technology. So I think, yes, we are able to do things that we couldn't do 15 years ago.
Okay, fantastic. And are there areas, certain, when I think about, when you listen to some of the talks about some of the gynae cancers, ovarian cancers, are there cancers that are completely resistant that you would just not approach with this technology? Or just not amenable by virtue of location or access?
Before, I think, this new technology, we had, I think it was a kind of myth, the radio-resistant tumors. We had a cancer of the kidney or melanoma. I think those days we couldn't give high dose of radiation, couldn't locate well. Today, we don't think there is such a thing called radio-resistant tumor. In principle, if you give appropriately, we can destroy, we can ablate most of these tumors.
Fantastic. Question about the cardio. I personally actually have had some of the patients who've received this. It's not, I know your primary interest, but clearly, obviously, you've been involved and it's a team effort. Do you ever see this sort of advancing to a point whereby it would be not sort of a last resort option, but perhaps something that would be used earlier on in the treatment of patients with cardiac arrhythmias?
I don't know if Tarek is still here.
So I'm here. I can definitely try to answer that one. We're seeing actually a resurgence of the use of radiation for more benign indications. So if you look at the rad-onc literature, it's starting to get bigger and bigger, the use of radiation for non-oncologic indications. So benign stuff like the cardiology thing you just mentioned. And I believe our next grand rounds from rad-onc will be about that, radiation for benign diseases. So what happens again, and it goes again with what we've been discussing, if we're able to reduce with technology to better target, to better reduce side effects, then the ratio between cost to benefit becomes more interesting for benign diseases. And this is where at some point we might see our treatments be moved a little bit earlier in the disease course of patients who have benign diseases, such as the ones that have the cardiology, the arrhythmias. We're not there yet, but I believe we're going there.
Okay. A question in the chat about how frequent is acute chronic collateral damage to other organs, example, rectum in prostate treatment during SBRT. Any way to measure in real time that radiation being actually delivered to the rectum and mitigate this?
Of course, one thing very important in radiation, particularly before the year 2000, we irradiated a large amount of normal tissues, and we could increase the dose of radiation. And as you know, if you have severe toxicity with radiation, it's almost impossible to cure. And this is a major concern. To give you an example, in rectal cancer, in prostate cancer, we do measure this prospectively, the bladder and the rectum. And if I can give you a number, during treatment, the patient doesn't feel anything. After a few days, or if the treatment takes a few days in prostate, because we give a little bit of radiation in part of the rectum of the bladder, most of the patients, they do feel that. I would say that at least 50% they feel that they need to urinate more frequently. They have more gas in the rectum. Most of the time, this is not the end of the world. It's easy for the patients to support this. And in general, after 2-3 weeks, this goes away. So the magic number, because it's difficult to report toxicity because you have to graduate the toxicity. One thing is to have a little bit of gas. The other thing is to have blood per rectum. So it's completely different types of toxicity. But I can give you a number. For late toxicity with this modern SBRT for prostate, it's less than 5%. The match number is 2-3% of important toxicity, meaning 95% of patients, they do well. We don't have we could have a way to measure this during treatment, but we don't need it. We have all these planning systems that I showed you that retrospectively, if there's any issue, we can go after and find the dose that any organ received after the treatment.
Okay, fantastic. Dr. Siderovich, who I'm sure has been involved in this dossier, makes a comment about MSSS was not actively trying to standardize treatments across the province. Is there any traction on this dossier now?
Yeah, Eva, I remember well when you invited me to to talk to you in the Harder Hospital because of this issue. And I'm sad to say, I don't think so. Each institution treats differently. And very often in the same institutions, we have different professionals doing a little bit different. Here in McGill, we have a kind of guidelines for every site, but not among services, no.
Just a sort of a general question. It seems that hearing you talk, you seem very enthusiastic about, how things are going and what you're able to offer. Would you say that you're offering sort of the latest technology available with very little wait time? That's kind of what I heard, which is impressive because obviously, I don't think that everyone has access to this across the board. Would you say that that's true, that you do really have sort of some of the latest technology with really no wait time? That's actually quite impressive if that's the case.
I'm going to give you my answer. If Tarek is around, I would appreciate it.
So I can do things if you want.
We do things that other institutions in many institutions in Quebec don't do it. And one of the reasons is because of the Cedar Cancer Center has the help of the foundation. And we have things that eventually the government would have more difficulty to pay, but we have it. Because we have this Department of Medical Physics that is amazingly good. We export physicists to the country. And this is amazingly important. But this is a field that the evolution doesn't stop. We do have the things more modern than we have today, and we're going to fight to have it. But in general, you're absolutely right. For instance, we see patients from other services of radiation oncology in Quebec because they are not able to do things that we are able to do. And if you go to different countries, this is well more pronounced. We have people that still do stop and shoot technique because they don't have facilities to do the arc therapy as I showed you. I don't know if Tarek can complete this.
So I would say, I just wanted to add one last thing is that we don't have proton therapy at the MUHC. Protons allow to target cancer even more precisely. I'm not going to go into details. And unfortunately, no center in Canada has it yet. We've been trying to get it, but it hasn't yet happened. The consequence is that today, protons, which are used mainly on pediatric cancer populations. So today, Quebec needs to send around 50 kids to the US to get treated. So I think that's really the biggest and most important gap in what we can offer.
Yeah, I see that Sonia Skemene made a comment about that. And at great expense, yes, Dr. Freeman. Does Toronto not have a project in the works? This is from Eva.
Yes, but it's a long way. They're looking at even better, well, not better, but even more complicated than protons, which is carbon ion. And it might take a decade maybe, but they have ideas too, but it's also a long way before happening. They're still at the conception phase.
Just from my point of view, one last question for me, and we'll see if there's other questions in the chat, but just a big picture point of view. If I understand correctly, you have these, MRI and CT superimposing capability. which is, obviously you showed us some really very impressive pictures there, and I can understand how that can advance your capacity to treat patients. So that's wonderful. Is that something that could be used by other groups in certain situations? I'm sure your machines are fully busy, but I'm just curious, like, what is it that allows you to have the ability to do some of these high-tech things? And are there machines that are kind of, not fully utilized by your team, or could you imagine other groups using that kind of technology? I'm not talking about the radiation part. I'm talking about the imaging part. And it's a tough question.
So I can give. Sorry, I'll jump in again. I can give a quick answer. So the SIM, Center for Innovative Medicine, has asked to rent our MRI time, and they actually do. It's maybe half a day every week or 2 weeks. They use our MRI for diagnostic research studies. Their own techs come and they really just use the machine. And we have an agreement, budget transfers between the SIM and our departmental budget.
And allows them to do things that they cannot do in other machines, I guess is that the case?
I'm not sure why they decided to do it with us. Maybe the diagnostic is too busy. Maybe doing it in private is more expensive. But we still have a 3T machine, so which can do quite a few things.
Fantastic. So perhaps we can take the rest of this offline from my point of view. Dr. Faria, really exciting. First of all, thank you for the excellent lecture. Thank you for showing us. I think you've shown us the possibilities, and that your team, first of all, is working clearly as a whole team, is really doing advanced work at the MUHC, and that's really great to hear. So thank you very much for sharing with us, for your excellent presentation, and for answering all these questions. Tarek as well, thank you for joining us today. And I wish you good luck, and continue to do this. It's really wonderful. And we hope to see you back here in another year or two, and you can tell us how things are evolving. I wish everyone a really great afternoon, and thanks again for joining us. Please don't forget to answer the brief survey that'll be sent to you after the presentation. That will let us know that you were present today. Have a great afternoon, everyone. Thank you. Bye-bye.
Thank you.